In this video, we are going to cover blood pressure. Blood pressure is the pressure exerted by blood within the blood vessels. The pressure is at its greatest near the heart but decreases as the blood moves away from the heart. Blood pressure helps us to know the workings of the heart and the vessels of the body. BP is controlled by a variety of complex physiological mechanisms which allow both short-term adaptation and long-term maintenance of BP within a normal range. Blood pressure which is too high or too low can lead to a wide range of pathology. It can cause ruptured blood vessels, reduced perfusion to organs, and therefore the mechanisms which maintain BP homeostasis need to be healthy. Blood flow is the amount of blood flowing to an area in a given amount of time, and it is usually expressed in milliliters per minute. Blood pressure is the force of the blood against the blood vessel wall, and it is dependent on three things, that is, cardiac output, blood volume, and blood resistance. Cardiac output is a factor because it takes into the account the force of ventricular contractions. The blood pressure changes in response to changes in cardiac output. If the cardiac output increases, blood pressure also increases. If the cardiac output decreases, the blood pressure also decreases. If either the stroke volume or the heart rate increases, the cardiac output increases, and as a result, the blood pressure also increases. If the stroke volume or the heart rate decreases, the cardiac output and the blood pressure decreases. The volume of blood pumped out from the ventricle with each contraction is called the stroke volume, and it equals about 70 ml for an adult at rest. The volume of blood that is present in the body affects blood pressure. An increase in blood volume in the body increases the rate of blood flow to the heart, resulting in increased cardiac output. Blood volume makes a difference because more blood exerts a greater force on the blood vessel walls. Now let us see the factors which cause fluctuation in blood pressure. Physiological factors. Many factors influence arterial blood pressure, which may be affected by other factors such as age, gender, hormones, disease, and exercise, etc. Peripheral resistance is another physiological factor. In the circulatory system, this is the resistance of the blood vessel. The higher the resistance, the higher the arterial pressure upstream from the resistance to blood flow. Resistance is related to vessel radius, vessel length, blood viscosity, and smoothness of the blood vessel walls. Blood viscosity. Viscosity means the thickness and stiffness of blood. The amount of albumins and red blood cells determine the thickness of blood. Thicker blood offers more resistance to flow and requires more pressure to get into move. An increase in viscosity of the blood increases blood pressure. The resistance is provided by plasma proteins and other substances in the blood. Next, vessel length. The greater the vessel length, the more friction occurs between the blood and the vessel walls. Friction slows the blood flow. Vessel length becomes a factor in people who are obese. More pressure is needed to propel blood through their longer system of vessels to feed their increased tissue mass. Next is vessel radius. The larger the radius, the lower the resistance. Vessel radius becomes a factor because the smaller the radius, the more blood comes in contact with the walls of the vessel. Vessel radius can be controlled through vasoconstriction and vasodilation in several different ways to regulate blood pressure. Blood pressure can be measured in a number of different ways, with the most common being systolic and diastolic blood pressure. Systolic blood pressure represents the pressure in the blood vessels when the heart contracts. Diastolic blood pressure represents the pressure in the blood vessels between heartbeats, that is, when it is relaxed. Mean arterial blood pressure is another method of assessing blood pressure. Mean arterial blood pressure is equal to cardiac output into systemic vascular resistance. Mean arterial blood pressure can be calculated from the systolic blood pressure and diastolic blood pressure using the following formula. mean arterial blood pressure is equal to diastolic blood pressure plus pulse pressure divided by 3. Pulse pressure is calculated by subtracting diastolic blood pressure from systolic blood pressure. Now let us see how our body is controlling BP. The BP is regulated by many factors such as neuronal regulation, that is through autonomic nervous system, autoregulation, that is through the renin-angiotensin-aldosterone system, then baroreceptors, chemoreceptors, hypothalamus, and circulating hormones. Circulating hormones are adrenaline, noradrenaline, and renin are the main examples of circulating hormones. Baroreceptor reflex is a neurally mediated reflex that regulates blood pressure in the short term. This reflex is crucial for maintaining blood pressure throughout the day, and in its absence, even a slight change in posture could lead to significant change in the blood pressure. There are mechanoreceptors known as baroreceptors located in the aortic arc and at the bifurcation of common carotid artery into external and internal carotids, which constantly monitor the mean arterial blood pressure and pulse pressure, and they are sensitive to pressure changes within the blood vessel. They sense the blood pressure and relay the information to the brain so that a proper blood pressure can be maintained and detect changes in blood pressure. Increases in arterial pressure stimulate baroreceptors and the heart rate and arterial pressure decrease. Decreases in arterial pressure reduce stimulation of the baroreceptors and vasoconstriction occurs, as does an increase in heart rate. When the blood pressure increases, signals are sent to cardioregulatory center in the brainstem. Increases in arterial pressure result in increased baroreceptor activity, increase in the firing rate in the associated afferent neurons carrying this information to the cardiovascular center in the medulla. In response to this, the parasympathetic nervous system activity increases and the sympathetic nervous system activity decreases. The net effect is reduced heart rate and systemic vasodilation, collectively reducing mean arterial blood pressure. On the other hand, if the blood pressure decreases, there is less baroreceptor activation, meaning the impulse rate of the afferent fibers decreases, causing the cardiovascular center to increase sympathetic nervous system outflow and decrease parasympathetic nervous system outflow. The cardioregulatory center increases the sympathetic activity to the heart and the blood vessels, thus increasing heart rate and vasoconstriction, resulting in increased blood pressure. The net effect of this is increased cardiac contractility, increased heart rate, and increased systemic vasoconstriction, causing an overall increase in blood pressure. Next is chemoreceptors. Chemoreceptors are found close to the carotid and aortic baroreceptors in small stretches called carotid bodies and aortic bodies. They are sensitive to any change in the chemical composition of the blood, such as a decrease in oxygen level and pH of the blood or an increase in the carbon dioxide level. These receptors send impulses to the cardiovascular center, which in turn increase the sympathetic stimulation to the blood vessels, causing an increase in blood pressure. Chemoreceptors also stimulate the respiratory centers in the brain to increase the rate of respiration. Next is hypothalamus. The hypothalamus responds to stimuli such as emotion, pain, anger, and it stimulates sympathetic nervous system activity, affecting blood pressure. Next is stretch receptors. It is located in the vena cava and the right atrium, respond to pressure changes that affect circulatory blood volume. When the BP decreases as a result of hypovolemia, a sympathetic response occurs, causing an increased heart rate and blood vessel constriction. When the BP increases as a result of hypervolemia, an opposite effect occurs. Specialized stretch receptors responding to pressure at key places within the cardiovascular system provides the brain with information regarding moment-to-moment changes in arterial blood pressure, that is aortic and carotid baroreceptors or venous blood volume. that is cardiopulmonary baroreceptors. This afferent input controls a variety of reflex responses encompassing autonomic, endocrine, and behavioral adjustments, each geared toward maintaining cardiovascular homeostasis. Key among these reflexes is the adjustment of autonomic outflow and the central neural pathways. Next is circulating hormones. Hormones such as antidiuretic hormones and atrial natriuretic peptide hormones help to regulate circulating blood volume by fluid and electrolyte regulation, thus affecting blood pressure. It is released when the body is dehydrated and causes the kidneys to conserve water, thus concentrating the urine and reducing its volume. At high concentrations, it also raises blood pressure by inducing moderate vasoconstriction. Atrial natriuretic peptide. ANP is a powerful vasodilator and a protein hormone secreted by heart muscle cells. It is released by the atria of the heart. ANP is a vasoactive peptide released in response to a rise in atrial pressures, which in turn are linked to venous pressure. ANP lowers blood pressure primarily by vasodilation and the inhibition of sodium reabsorption by the kidney, the latter having a diuretic effect. This system increases sodium excretion in part through the opposition of the renin-angiotensin-aldosterone system, inhibiting renin and aldosterone release. ANP has also been shown to have inhibitory effects on vasopressin. ANP acts to reduce the water, sodium, and adipose levels in the circulatory system, thereby reducing blood pressure. Next is renin-angiotensin-aldosterone system or RAS. RAS is an essential component of blood pressure regulation that acts to increase blood volume and increase systemic vascular resistance. Renin, a potent vasoconstrictor, causes the BP to increase. When blood volume is low, juxtaglomerular cells in the kidneys secrete renin directly into circulation. Plasma renin then carries out the conversion of angiotensinogen released by the liver to angiotensin 1. Angiotensin 1 is subsequently converted to angiotensin 2 by the angiotensin converting enzyme found in the lungs. Angiotensin 2 stimulates the release of aldosterone, which promotes water and sodium retention by the kidneys. This action increases blood volume and BP. Angiotensin 2 is also capable of increasing plasma volume through the stimulation of thirst and antidiuretic hormone, another regulator of blood pressure, which will be discussed shortly. Aldosterone acts on the principal cell found in the DCT, that is distal convoluted tubule, and collecting duct of the nephron, increasing sodium reabsorption while simultaneously increasing potassium secretion into the tubules. Aldosterone is having the ability to increase the volume of the extracellular fluid compartment and thus BP. Several common antihypertensive medications aim to decrease blood pressure through inhibition of aldosterone formation. Next is antidiuretic hormone. Antidiuretic hormone, also known as vasopressin, is involved in the control of blood pressure. Antidiuretic hormone is made by cell bodies located in the hypothalamus and released from the adjacent posterior pituitary gland. Antidiuretic hormone influences BP indirectly by regulating vascular volume. Increases in blood volume result in decreased antidiuretic hormone release, increase in diuresis, decreasing blood volume and thus decreasing BP. Decreases in blood volume result in increased antidiuretic hormone release. This promotes an increase in blood volume and therefore increase in BP. ADH increases water reabsorption by binding to V2 receptors. When someone becomes dehydrated, the osmolarity of the extracellular fluid increases, leading to ADH release from the pituitary gland, that is posterior pituitary gland. Water is then reabsorbed at an increased rate at the level of the kidney, ultimately acting to increase the intravascular fluid volume. This increases blood pressure through an increase in venous pressure, thereby boosting venous return to the heart and increasing cardiac output. ADH also acts as a vasoconstrictor, targeting V1 receptors on vascular smooth muscle at high concentrations, such as in response to hemorrhagic shock. Next is how to take blood pressure. Blood pressure is measured using a sphygmomanometer. It can be electronic, digital, or aneroids. And it is a non-invasive method of monitoring a patient's blood pressure. It may be used as a diagnostic test on patients with arterial blood pressure problems. It can be recorded with the patient sitting comfortably in a chair or lying in bed. Ambulatory blood pressure monitoring is also sometimes used to check how well medicine used to treat hypertension is working. Ambulatory blood pressure monitoring is a method to measure your blood pressure on a continuous basis for 24 hours. Blood pressure is usually measured in the brachial artery by using a sphygmomanometer that has a pressure cuff and a device to inflate the cuff. The original instruments, that is a sphygmomanometer, measured blood pressure as the amount of pressure necessary to lift a column of mercury a certain distance. So the units for blood pressure are millimeters of mercury. Newer sphygmomanometers typically use a dial to indicate pressure using the same units. Two pressures are recorded and expressed as systolic pressure and diastolic pressure. For example, a normal blood pressure for a 20 to 30-year-old is 120 by 72 mmHg. The systolic pressure created in the brachial artery during ventricular systole is 120 mmHg. The diastolic pressure created in the brachial artery during ventricular diastole is 72 mmHg.